Good afternoon, everyone. It's a pleasure to be here. I want you all to know that I have, from Houston, signed and sealed and stamped travel papers that allow me to come to your city, from which I must return by midnight under penalty that the mayor would not tell me what it was. And of course, we all know that we live in the second best cities in Texas. Just ask anyone from Fort Worth. Right? Where the West begins, right? And when you've got the Kimball Museum and everything else in that wonderful city. I once stayed in a B&B in Fort Worth for a meeting and spent the first hour getting up the first morning battling with a scorpion in the sink. They have very hard exoskeletons. They're hard to kill. Then I realized it was his home, not mine, and we made peace. My goal this afternoon is, by fulfilling these objectives, is actually to try to normalize genomic and genetic ethics. I think genomics and genetics are a classic example of a medical specialty that's gotten siloed off from the rest of medicine, and as a consequence has its own discourse, even its own discourse like actionable. No other clinical specialty uses this, for example, and it's gotten actually troubles with the insurance companies because they won't pay for diagnostic workup. They worry about variants of unknown significance. Any of you who've gotten a radiology report is going to have on it, consistent with, right, all these language that radiologists use that have to be interpreted and then shared or not with patients. So I'm going to define ethics, and it's two main tools, so we're all on the same page, some core concepts, then the 5 clinical categories into which genome results fall, and they're the exact same categories into which every other clinical results fall, and then an ethical framework for dealing with this in the decision-making process with patients and also with parents. There are some special wrinkles in pediatrics. So what is ethics? It's a very old intellectual and practical undertaking. You find it in global cultures all around the world going back to ancient times. It's the disciplined study of morality. Morality concerns our behavior, how we should act toward each other, and also our character, what virtues we should cultivate so that we're better persons, and what vices we should avoid. So Mr. Trump has the vice of a potty mouth, for example, and I was thinking over the last 72 hours that if my sainted mother, as we Irish refer to our dead, were alive, she would wash his mouth out, not with soap, but with borax. I had that experience once, and I never said that word again until I was an adult, and then I looked around to see if my mother was there. And the way we do this is by ethical analysis, is getting very clear about pertinent ethical concepts and then identifying their implications for how we should act or how we should form our character so that we give reasoned accounts of what morality should be. And the goal is to improve our morality, that we can be better people, we can have better institutions, we can have a better society if we think together carefully about it and reach judgments about how to improve. Whoops, I don't know what I just did. So what are the key concepts that we need? First is beneficence. This is one of the oldest concepts in the history of medical ethics. It's a simple concept. It says clinicians should provide clinical management for patients that has an evidence base for net clinical benefit. This concept of beneficence was first introduced into the medical ethics literature in 1803 by Thomas Percival in England with exactly that meaning. He was one of the first practitioners of evidence-based medicine in the history of medicine. Then we forgot it in the 19th and early 20th century, and now we have to recover it. We are a remarkably unintelligent species sometimes. We learn stuff, then we forget it and have to relearn it. So you look for deliberative clinical judgment that's evidence-based, that's rigorous, transparent, and accountable, just of the kind we've been seeing in the presentations today, and you make judgments based on that about what will benefit the patient. Professional integrity says you practice medicine or healthcare, teach and conduct research to standards of intellectual and moral excellence. Intellectual excellence is adhering to the discipline of deliberative clinical judgment, and moral excellence is you put the interests of patients and their families first, and you keep self-interest systematically secondary. We use this word patient without being clear what it means. A patient is someone who is presented to a healthcare professional, and there's something that can be done to help, and they don't have to be presented in person. They can be presented at a distance. So a friend of mine has friends in Jerusalem, Israel, who are board certified American radiologists. They just happen to be Israelis, and They are practicing radiology on patients in the United States. The digitized images are sent by a computer to their computers during our night and their day. They interpret the images, write up their reports, and they're ready the next morning for the care of those patients. So they are presented. How are they presented? Through digitized images. In the 18th century, Thomas Percival would have had patients presented to him by sending him letters. So patients frequently wrote to famous doctors and said, here's my story, please send a diagnosis and a treatment plan. And famous doctors would oblige and become more famous if their treatments worked. So it's very easy to become a patient, and it has important implications in genomics. You can be presented through your kinfolk's genome to a doctor. Right? So if I have my genome sequenced, my kinfolk are presented in that, because it's not just about me. They become that analyst's patient, which makes it more complicated, and the way to prevent these ethical problems is to turn the clock back and stop science. Good luck with that alternative. Medically reasonable means that in beneficence-based clinical judgment, a clinical alternative is both technically possible and expected to be beneficial. So it's technically possible to sequence every genome of every person in this room. The question is it medically reasonable? Would it yield information that would make a difference in the patient care? If it's technically possible, but not medically reasonable, it violates professional integrity to offer or do it. So you don't. Even when patients ask, you don't. Even when patients insist, you don't. Or as in our state, where you're allowed to carry concealed firearms, if the patient's arm is not going completely down to the side because there's a large caliber weapon under that arm, you still don't do it. Even in Dallas, you don't do it, right? Seriously, this gets clinicians into a great deal of trouble. You lose control of this. So if a patient says, I want my genome sequenced, you have to say, that's interesting. I need to make a professional judgment about whether that's a good idea. And then respect for autonomy is you empower a patient with information about what's medically reasonable for the management of their condition. Now, this is very different from another concept of autonomy in the bioethics literature, is you respect and implement patients' rights with no constraint of professional integrity. We could go down that route, but that would be to turn the clock back to before the 18th century when professional medical ethics was invented by Dr. Percival, among others, and go back to a purely contractual model of healthcare in which it was no longer a profession. We could do that. There's no obligation to maintain a profession. It happens to be in our interest as patients that we have the professions, and it's certainly in the interest of the people who practice them. It's very, very difficult to be a healthcare professional. If you become a mere technician, it's going to become even more difficult, and all the money in the world's not going to make it worth doing. That's my own judgment about this. So this is respect for autonomy in a professional ethical setting, not in the standard bioethics setting. So here's what you get back when you send in. This is what you get back whenever you do any kind of analysis on human material. You're going to get a diagnosis, including a diagnosis you weren't expecting. Not unusual at all. That happens all the time. I'm the ethicist for our fetal center at the Pavilion for Women at Texas Children's Hospital. Every Thursday morning, we go through all the new cases. Last Thursday morning, an MR image went up of a fetus, and there was clearly something wrong with the woman's kidney. So that was a diagnosis she was not expecting, but had to be made because it was an urgent problem that required attention. So you get diagnoses back you're not expecting. Next is risk assessment of two kinds, for future health and for reproductive risk assessment. And we've been doing risk assessment in medicine for a very long time. If you diagnose a patient with schizophrenia, you know something about risk assessment for other members of that patient's family, just by reason of making that diagnosis. If you are a fair-skinned Irishman like me and live in Texas, you have a increased risk for skin cancers. So what does my dermatologist tell me to do? Cover up, right? You know, so, and how do you cover up when, right? We don't have the sun in Texas. We have something different, right? I grew up in Massachusetts. There, it's the sun. Up there in Yankee land, right? It's the sun. Here, it's this burning object in the sky, right? Threatening to scoop us all up and turn us into cinders. Then there are genes and variants of unknown clinical significance, but that's simply the category you get in any clinical analysis. There are going to be some things whose clinical significance is not known. And that's a simple category I'm going to explain. That's theoretical interest only. It's not clinically salient. You don't have to disclose it. But because it can be interpreted later, we got to find a way to save it. And then come pharmacogenomics, which we've seen a lot about already this afternoon, and that is refining drug treatment based on our genomic information. This is going to be enormously valuable for patients as it becomes built up. Now, we need to talk about these incidental findings. They occur in the context of when you're doing a targeted analysis. That is, you're looking for something in particular, but since you're doing a broad spectrum analysis, you're going to get things outside that scope. These are called incidental findings, secondary findings, or additional findings. It depends on whether they fall into one of these categories, their significance. So there's nothing special about the category, even though there's a paper called the incidentalome, right, in the genomic ethics literature. I looked at that and I said, you don't find this in the radiology literature or pathology literature. And then if you're doing it in a non-targeted way, that is with pre-symptomatic patients, the category of incidental findings has very limited or no application. Now, what's a major lesson from the history of medicine? Diagnostic power always exceeds and leads therapeutic power. And doctors have been complaining about this for centuries, and so have patients. So it's not at all unusual that the diagnostic capability of genomics is way out in front of its clinical applications. That's just fine. That is standard in the history of medicine and will continue to be repeated as every new diagnostic technology comes online. By the way, the biophysicists are waiting to put the genome scientists out of business because it's atoms that really determine human health, not giant things like molecules, right? So if you're waiting for a scientific revolution, just wait, because it's coming. And won't that be fun, explaining biophysics to patients, right? So what's the point of diagnosis? It's the sine qua non of all healthcare, because it puts the patient into a clinical category that tells you, clinicians, what the patient has, and then we know about what management works for that diagnosis and what doesn't, what's beneficial, what's ineffective, and what's dangerous. This has intrinsic value, just naming it. It's really important. It has enormously intrinsic value for patients and for parents of sick kids. They want to know what the name of the problem is. And that, interestingly, gives us a sense of control and power over it, even though we can't treat it. So it's really, really important. And it also obviously has instrumental value, especially in children, is bringing an end to the diagnostic odyssey, especially for kiddos with developmental disorders. If you can bring that to an end, think of all the iatrogenic morbidity you have now prevented for that child in the future, which is an enormous clinical benefit, even though it's not actionable. That's where that word begins to cause all kinds of ethical problems, as I note here. It should not be used and be replaced with clinical significance. So is it always clinically significant to get a diagnosis? Yes, because all clinical management is based on that. When you can't get a diagnosis, right, that's when clinician gets nervous because the risk of error goes up. And so there's enormous value for getting diagnosis, so we should stop using this language of actionable and go back to the traditional language of medicine. Now, should insurance companies pay for diagnostic workups that are evidence-based? And the answer is yes. Should insurance companies pay for workups that aren't actionable? No, that's the trap, right? That's the trap. So stop using the language, right? When your pain receptors have been activated by the steel claws of a trap, you should look down and say, ooh, that's where the pain is coming from, right? So this is a trap that genomics and geneticists set for themselves. They simply need to open the claws and say, that was a boo-boo, and stop using the word. Now, what's the professional responsibility in the informed consent process? Generally, healthcare professionals should explain the patient's condition, disease, injury, or disability, the diagnosis the patient has, a differential diagnosis and risk assessment, what are the medically reasonable alternatives for managing these, and what are the clinical benefits and risks of each medically reasonable alternatives. What are the categories that they're going to fall into that are clinically salient? There are just 4 of them: diagnosis, risk assessment for future health, reproductive risk assessment, and pharmacogenomics. standard clinical practice. And then the category not ethical to disclose are the genes and genetic variants of unknown significance. But we do need to save them because they could be interpreted to become significant later. And so we need to find a way to store them and then notify the referring physician that there is now a new analysis. This isn't settled, but it strikes me the responsibility rests with the genome laboratories because that's standard in pathology. If a pathologist goes back and re-examines tissue because there's evidence that's been reported that it's worth doing that and discovers something clinically significant, it's the pathologist's job to report that to the doctor who ordered the analysis. It's not the doctor who ordered its job to keep asking the pathologist, anything new, anything new. It's the pathologist's job. So in many ways, genome scientists need to think like pathologists and follow their ethics. So, by the way, and this includes giving diagnoses that can't be treated. And this happens all the time in medicine. There's some examples there. There are progressive diseases, conditions that result in disability, for example, congestive heart failure or Parkinson's disease or diagnosis of a fetus with trisomy 18. Some of these are life-taking. Obstetricians or pediatricians may need to tell a pregnant woman or new parents that the fetus or a baby has sthenic diphoric dysplasia type 1, which is a lethal diagnosis. It's not easy to do. It's dreaded to have to do this by clinicians and has been for centuries, but it has to be done nonetheless, and genetic diagnoses are no exception. Now, there was a debate in the genetic ethics literature about do geneticists have a therapeutic privilege? That is the prerogative to withhold information that has been discovered that is clinically significant but could be so psychologically threatening to the patient should not be told. In general, there is no therapeutic privilege in medical law or medical ethics because it's not whether the information is given, it's how it's given that creates the psychological threat to patients. So if geneticists and genomic scientists are going to invoke therapeutic privilege, they face an enormously steep burden of proof, and they might not be able to meet it. So this is a category that you need to know about, but it might not have any members. The issue is how we convey this information to patients or their parents and family members rather than whether it's conveyed to them. And it obviously has to be done with great sensitivity and support. So the informed consent process, right, is that you have to tell patients we may learn diagnoses that are helpful. We may learn diagnoses for which there's no effective treatment. We could get an unexpected diagnosis. This is the incidental, secondary, or additional finding. We could get increased risk related to your future health. We can get increased reproductive risk, and we can get a pharmacogenomic indication to change your current drug regimen if that's what you're on, or a future one should you need that drug for the management of a disease later in your life. Again, these are not remarkable categories. These are standard categories. The last one's pharmacogenomic. The only thing distinctive about it is the genomic part of that big long word. Adjusting pharmacological management for a variety of conditions, for example, the patient's dietary habits, right, is well known as a challenge that has to be addressed. This is simply one more area of information that lets us do that. Now, how do you deal with refusals, which I think are going to be rare because patients rarely refuse what is offered or recommended. But when they do, it can be a major ethical problem. So first of all, if a patient refuses the recommended genetic or genomic analysis, rule out the most common reason why patients refuse recommended courses of management generally, and that is inadvertent miscommunication by somebody in the multidisciplinary team. And also rule out what they're learning on their own. That's bad information. In other words, patients are making a rational decision based on bad information. If you correct the information and they exercise their rational faculties, they should withdraw that refusal and consider what you're offering. Also assume that patients have a good reason for what they're doing, that they're not crazy, that by their lights they got things they want to accomplish and get done. I mean, I never forget a patient on rounds at the VA in Houston who absolutely refused amputation of his very gangrenous left leg, and the team thought he was incompetent. So I said, ask him why he wants to do that. And he was a classic good old boy from the piney woods of East Texas, and he said, God made me in one piece, and I'm going to get buried in one piece. And the team said to him, well, to do that, you're going to have to die from a treatable condition. He said, okay with me. And they did everything they could to persuade him to change, and he wouldn't. So ask patients what their understanding is, ask what's important to patients, what do they want to accomplish by this refusal, and listen for values that will support what you're offering or recommending. This is a very important area. The third bullet is watch out for cognitive biases. We have this image, especially from economics, before it learned psychology, of the rational decision maker who has perfect information. There's no such thing. There are human beings dealing with incomplete information, evaluating them subject to all kinds of biases. Now, I read this literature with great curiosity because I have a PhD in philosophy. And when you get a PhD in philosophy, you have conferred on you lifetime rationality. So when my mentor, Chet Lieb, put my hood on me at UT in May of 1976, he said, and you will be rational for the rest of your life, even though you're of Irish extraction, right? Which is not ersatz genetics, that's genetics, right? Obviously, all of us are subject to these. So the anchoring bias, we anchor our judgments in something really good or really bad that happened in the recent past, and it's not relevant to what we're doing. Classic example, patients we see at the VA will refuse treatment for their cancer because Uncle Charlie died of it, and we say, when? 1949. Say, well, everybody died of cancer in 1949 because there were no treatments. This one actually works. And they go, oh, then I'll have it. When it is the case, point out when their values support what you're doing. Explain both the intrinsic and instrumental value of getting a diagnosis if you can, or at least trying to refine a differential diagnosis, and then make a recommendation. Now, there is a legal requirement that has to be made, and this is called informed refusal. So when a patient refuses what you are offering as clinically valuable to the patient, you have to provide the patient with a list of the biopsychosocial risks the patient is taking. As near as I can tell, here they are. You're going to lose the intrinsic value of learning a diagnosis or refining a differential diagnosis. You're going to lose the opportunity to learn new information about yourself that could be clinically very valuable. For example, an unexpected diagnosis, and maybe one that we could treat. Losing the benefit of ending a diagnostic odyssey. You're going to keep going from doctor to doctor to doctor, and by the way, in a world of underinsurance, right, the copays and deductibles or that could be really frightful. I was very impressed to learn at lunch that that young family, right, by February they've hit their deductible, right? That's not true for me. It would have been in 1988 when I first started at Baylor. My deductible, my out-of-pocket risk in the PPO at Baylor was $600 for each of me and my wife. It's now $5,000 for each of us. What's Baylor done? Shifted cost onto its employees. Why? Because that's economically rational business practice. That's why. That's the world we live in. So I have to have that money on hand, but I have a named chair, right? So I have the money to do that. And a considerable percent of my chair income goes right into the savings account every year, right? You're going to have an increased risk of clinically unnecessary and potentially morbid subsequent clinical management. Think about that. Ineffective management and increased uncertainty of what your current condition is, and increased personal cost, out-of-pocket cost. That can be very significant. Then you're done. If you've disclosed all these risks, you've met your legal obligation, you document that in the record. There's this urban myth that patients have to sign informed refusals. They don't. And by the way, in electronic records, they can't sign because they don't have a password in the Epic or system, whatever it is you're using, to make their electronic signature. You've then met your legal duty. Then you do your ethical obligations. This is a classic example of where ethics and law are not equivalent. The law says, tell them all the risks they're going to take, document it in the record, and you're done. If they want to be clinically foolish, that's their business. Not for any conscientious clinician of integrity. It's your business. You want to try to persuade them to reconsider, and here's that same list again as I had earlier, especially that last one. Be willing to recommend and re-recommend and re-recommend what you're offering. Don't abandon your patients. Stay with them, even though these patients can sometimes drive you to distraction. What's the ethics of risk assessment? Doctors have been doing this for a very long time, as have nurses and public health officials, right? So why is the MD Anderson Cancer Center in Houston? Other than for political reasons. What are we just west of in Houston? The largest petrochemical refining complex on the planet, right, which is producing carcinogens by the ton, which are good for us in Houston. Right? So what do we know by people who live downstream? And the public health authorities have these data. If you're in the downstream wind zones from that petrochemical refining plants, there's increased risk of cancer there. There's no doubt about it. We know about this. So if you want to live in Friendswood rather than my neighborhood, you're taking an increased risk to your health. But this is simply primary and secondary prevention, and it's part of standard primary care and has been for a long time. Now the challenge is getting patients to understand what risk assessment means. That I have an increased risk for disease X does not mean I have it. It means compared to most other folks, I'm more likely to get it. We saw the nice example earlier about that 1.2, right? It depends on what it's a 1.2 of. If it's a 1% risk, going up to 1.2%, not a big deal. If it's a 20% risk going up to 24%, maybe, right? So what is the increased risk and what should I do about it? By the way, do we make risk assessments? All of us will make, I won't. The person driving my taxi back to Love Field will make what risk assessment? How fast to go on the tollway over there, right? And we all know how Texans manage risk assessment on the road when it rains, at least in Houston. You go faster. And do you know the scientific reason for that? When the coefficient of friction under your tires is less than 1, that only applies to Yankees. Does not apply to Texans. That's actually in every Physics 101 textbook in the world, right? And then again, be alert to cognitive biases that people have. You mean I'm going to get this disease, doctor? No, it doesn't mean that. What does it mean clinically? We're going to be watching for this together. And if I see changes that are indicating the onset of this disease, then we're going to respond more quickly. This gives us an advantage. We can find out your problem earlier and respond to it earlier, and as a rule in healthcare, earlier treatment and workup results in better outcomes. So what's the ethics of informed consent? You identify the forms of genetic or genomic analysis that are medically reasonable, and you got some very good information today about how to do that, especially the fundamental questions you should ask yourself as a clinician. Then explain the nature and type of genetic genomic analysis in general terms, right? We get increasingly refined, complex, and detailed results as we go from arrays to whole exome to whole genome sequencing. That's the basic concept. We get more, and it's more complex. You then offer or recommend based on deliberative clinical judgment, and then you identify the results that are going to come back. You're going to get diagnostic information, you're going to get risk assessment information, and pharmacogenomic information, and I'm going to share those with you. That will be a matter of routine. There'll be variants of unknown significance. I'm not going to share those with you. We're going to store those, and if they become significant later, we'll be back in contact with you, and then explain results that won't be provided based on therapeutic privilege, if you could ever justify that. I'm not sure that you could, but I had to include that I think that is at least a theoretical possibility. So I had this experience. I had a bad sinus infection several years ago, and my primary care doctor said, this is not what you usually have each winter, Larry. You need to go see one of the Baylor ENTs. So I did, and she ordered a CT in this part of my head. I was glad to discover that my third grade teacher was wrong. This is not full of rocks, coal, and swirling dust. ENT actually showed me the lower parts of my brain on that scan, so I was very reassured by that. And she said, there's an artifact in this, and we're not going to discuss it. Now, what was that? It was an invitation whether I wanted to be obsessive or not. So I said, no. And she said, fine, no major problems. You don't need to see me anymore. And I breathed a sigh of relief and went back to what I was doing. So that's how you handle it. You just say, we're not going to discuss it. And most patients will say, fine. They will trust your judgment. Those who are obsessive or who don't trust your judgment, they're going to ask for this information. Now, what's the risk of giving variants of unknown significance is going to be information overload, which we know short-circuits the exercise of decision-making. So even then I would say you should recommend against it because it's going to give you information that could distract you, spend a lot of time. What are you going to do with all those variants of unknown significance before you get home, right? out comes this device, and people start searching, right? And get all kinds of unedited information unless they go to good sites like the NIH or the professional sites where you can get information that's reliable. Now, how does this work in pediatrics? In pediatrics, according to the American Academy of Pediatrics, parents don't give informed consent for their children's care because they and pediatricians are bound by the best interest of the child standard. So parents are asked to give permission for what the pediatric professional judges to be in the child's interest. And ethically, they're actually not free to refuse. Legally, that becomes a whole separate question. So results will be provided that pertain to the risk of adult-onset conditions or diseases, the results of which can be modified during childhood. I think there's agreement on that one in the ethics literature. And reproductive assessment, not when they're adults and thinking about getting married, but before they become sexually active. That's the standard in adolescent medicine, is you start counseling adolescents about responsible sexual behavior when they're about to become sexually active, ideally before, right? If you have reproductive risks, that's something you need to be aware about because your sexual partner or you may not be acting in ways that are known to prevent a pregnancy if you're engaging in heterosexual sexual intercourse. This simply adds a dimension to the kind of counseling that should be going on about responsible sexuality for teenagers in a standard pediatric practice. Now, here comes the controversy. There really is disagreement on this one. It's not settled at all, and that is giving information about adult-onset conditions, the risk of which is not modifiable until you're an adult. One view, I think if we counted noses in the ethics literature, I think this is the more common view, not necessarily the more well-argued one, is don't provide it to protect what's called the child's open future, which is a fuzzy concept, but means basically don't arbitrarily reduce a child's future choices by giving information that doesn't make any difference to the kid now. They can't do anything about it. But what's a limitation on this, if you go back to one of those slides, from the newborn screening talk, there were those ones that I was watching, those bars. Some of those are adult onset and some of those are early onset. The distinction between an adult onset and an early onset condition is not always going to be easy to make. And be careful about that. So if you're going to go this way, explain the limitation on this and then offering the results when you're not certain, which it is. The other view is that the risks to open future are justified to take because of the value of the information that gives for preparing children to become responsible adults, which is part of child rearing. And so that's a counter argument to this. This argument rages on in the genetic ethics literature. There's no settled view on it. As I said, the most dominant view is the first one, but the second one I think is beginning to gain adherence. Confidentiality, there's no difference in genomic information than any other medical information that's in a patient's record. It must be protected from unauthorized access, right? Including, by the way, from healthcare professionals who are not responsible for the care of that patient, right? So I have EPIC privileges at our teaching hospitals, but only for the purposes of ethics consultation. I just can't go into EPIC and say, gee, I wonder who's in bed 16 in intensive care unit 4 in hospital Y. I can't do that because I have no authorization to do that. And the nice thing about electronic medical records is if I ever did do that, those hospital administrators will know that I did, right? Because you got to sign in and you're leaving an electronic trail. The old days, you could just go and pull a record off the chart, off the shelf and read it if you wanted to. Then you left fingerprints, I guess. Someone could fingerprint it. But there's a beneficence-based obligation to maintain confidentiality because we patients aren't going to tell clinicians our secrets unless you're going to keep them for us. And there's a professional integrity-based obligation. You know that if patients don't give you that information, your ability to manage their care responsibly is impaired. And there are laws about this. So there's HIPAA, the Health Insurance Portability and Accountability Act, and according to one of my ENT surgeon friends, says if you say HIPAA 3 times quickly, you'll have uncontrollable spasms of the upper airway, so don't do that. And I've never tested that scientifically and don't recommend that you do either. And then there's the GINA, the Genetic Information Non-Discrimination Act. Now, when it comes to individual purchase of life insurance and disability, and before the Affordable Care Act, because that's gone now, so life insurance and disability insurance, by individuals, They are allowed to use information about your health to decide whether to underwrite you, and then if they decide that, what premium they're going to charge you, because none of us have a right to that. That's a very good thing to have. It's a good thing to have adequate life insurance if you're a good personal financial planner. It's a good thing to have disability insurance to protect your income. Most of us get that through our employers. Employers can't discriminate against us already because it's in the plan. So every new employee at Baylor goes right into the health plan. Doesn't matter what their risks are, what their medical information is. But if I want to buy an individual life insurance policy, which I've done, I have to agree to all kinds of stuff, and that goes into the life insurance data pool, which, by the way, has never been breached, or at least that we don't, to our knowledge. Why? If you're one of the major life insurance underwriters in this country, would you dare risk a data breach of that medical database? What would it do to your business? Destroy it, right? What happens when Americans withdraw their trusts from powerful social institutions? We don't give it back, right? So suppose tomorrow morning the director of the CIA says that Guatemala poses a major military threat to the United States, and he's got the evidence to prove it. How many of you would believe him? Suppose he says, I'm sorry, I didn't mean Guatemala, I meant Russia. They're massing troops and they're about to invade the Baltic states. Would you believe him? We're all from Missouri. I'd say, show me the satellite images and prove you didn't doctor them, right? So be careful. You never want to lose that trust that people have given to the healthcare professions. Practicing, again, healthcare is a very demanding way of life. If you were doing it in an atmosphere of corrosive distrust, I think it would become impossible to do it. So conclusions, this is against genomic or genetic exceptionalism in the area of ethics. The ethics of diagnosis using genetic or genomic information is exactly the same as the rest of healthcare. And just the same as doing a history. Can you discover something unexpected by doing a physical exam on a patient the patient didn't know about? How many of us are good at observing skin changes on our back? Where what cancer can begin? Melanomas, right? How many mirrors do you have to line yourself up in front of to see your own back? And people who don't live with someone else who can look at it for them, and besides it's an amateur, what would they know? So the difference of genetic information is its wider scope. There's a lot more of it. It's cognitively demanding for clinicians, and it's therefore cognitively demanding for patients. Now, could our colleagues in genome science make it simpler? Yes. I think they could. Why don't they make it simpler? Because they all understand it. Right? So it's a classic specialist discourse. It's designed to communicate to other specialists. It's got to be done in such a way that non-specialists can get it, especially, handing a genome report to a patient, right, is a perilous business. I've seen them, and I puzzle over what they mean, and I think I'm a pretty sophisticated consumer of medical information at this point in my life. The ethics of confidentiality, as I said, are just the same as for all other areas of clinical practice, and the ethical challenges of diagnosis and risk assessment should be managed just as they are with all other aspects of medicine. So I hope I persuaded you that genetics is an area of medicine that we should normalize and bring under standard professional ethics, and that once we do, the ethics is not different. As I said, it's that first inset bullet. The real difference is the nature, scope, and complexity of the information that we're getting. We've got to find a way to make that simple and still meaningful clinically and scientifically to the person giving it and to the clinicians who are receiving it and then using it. With that, I'll be glad to see if any of you all have any questions.
Excellent talk. I have a question about informed consent. And I think informed is the key word. Who should ask for informed consent? If I were, say, a neonatologist asking for families' permission to do genetic testing on their infant, because genetics is becoming so complex, I would not feel qualified to ask for informed consent. I'd be handing the family a piece of paper, could you sign this? So what process would you recommend for going through this issue? Do I refer them to the clinical geneticist down the hall, or do I do my best to have the patient or the family sign the consent?
Thank you. That's a terrific question. So when a neonatologist is going to order an MRI, right, of a patient, the neonatologist explains the nature of that examination to the parents, especially that there's no radiation involved, why it's going to be done, and what you hope to use with the information you get back. Then the baby is, or the child, the baby, is then usually taken to the MR suite, where the radiologist should explain the procedure in the kind of detail that only a radiologist can, and get the informed permission from the parents. That works very well when already genetics and genomics simply have to adopt the existing model. So for example, you may send a patient, a general physician may send a patient to a surgeon. The generalist will explain why they're making that referral and generally what the surgery would involve, but the description of it and the obtaining of consent for it is with the surgeon. We need the exact same approach to genome analysis. So we need qualified genomicists, genetic physicians, and genetic counselors, if they can do this work, who would explain the nature of the test, the kind of results that are going to come back, and the benefits of that, and then the risks that go with this.
The second question I have is, and that's certainly more controversial, is why should we obtain informed consent? I don't obtain informed consent for other sensitive tests, such as testing for STDs, which certainly have many implications, but just like genetic testing. So what makes genetic testing so much of a different animal than, say, if I order a VDRL?
That's a great question. I think you should stand there and keep asking great questions. Someone should record them, and we're going to get a really great article on the ethics of genetics when we're done. It depends on how you view informed consent. If you view it clinically, the main purpose of informed consent is to help patients manage risk. When a diagnostic modality has little or no risk associated with it, we get consent but not informed consent. So I have never been asked for informed consent for a needle stick, and don't expect to be asked for that, right? I'm just told, hold my finger out and don't faint, right? So I make sure I'm sitting down, right? No, I do. That's how I am with needles. So if genetic tests at some point become normalized enough that they are like many other diagnostic workups that are done on patients, all we'll need is consent, not informed consent. But if you think that autonomy is the fundamental ethical principle, and patients have a right to authorize everything that is done to them, and if you're concerned that there are especially biopsychosocial and psychosocial risks of genomic workup, then you're going to insist on informed consent, not to manage risk, but to respect rights. So the approach I would recommend is the first one. You take a professional ethics approach, and are we in a transition period with the newness of this diagnostic technology that it's not yet normalized? Once it is, now we got to be careful. Patients who get serial CT scans are oftentimes not told by the referring doctor and not told by the radiologist about cumulative dosing and its risks. So we because normally go for an X-ray, which a CT is, right? It's just that it's fancier and louder. You just go. Nobody talks to you about radiation risk and exposure. Well, that's now starting to change. So we got to be careful. If we normalize it, we could become casual about it in a way that we could drift into ethically risky, worrisome territory by not paying attention. But I think if we can normalize this in many respects, then we could get simple consent rather than informed consent. But I think that's, those answers I've given you are in deep contention with each other. That's not a settled matter at all, I think.
Thank you.
Hi. The first whole exome sequencing test that I did for one of my patients, the consent form was literally 9 pages long, and it took me over an hour to go through each line and have them initial what information they wanted. And I told them that I'm never going to do that again, so you're going to have to change that. That came from the lab.
That's an autonomy-based approach to consent rather than a professionally-based approach to consent. The professional approach is there are clinically significant categories of information we might get. Here they are.
Right.
We need your authorization to do this analysis, and if we get results back in those categories, we're going to share them with you and explain them. How long did I just take to do that?
Not very long. That's better.
And by the way, what's the risk of this for a patient? None. The risks are all psychosocial when the results are shared, and a good, competent clinician knows how to manage those. So we might be able to normalize this much more rapidly than we think. But that's an autonomy-based approach, which is it's a very dominant position in the ethical, legal, and social implications, the ELSI literature. That literature is not strongly influenced by professional medical ethics and professional nursing ethics.
So the actual question I had for you, though, that I was looking at the reasons why we do testing. And as a geneticist, one of the reasons that I want to do genetic testing is to offer patients reproductive risk, recurrence risk information. Unfortunately, none of the insurance companies that we deal with consider reproductive risks as a reason to test a child diagnostically. And although I consider the family my patient, not just that child that I'm testing, insurance companies don't see it that way. So if my only reason or my main reason for wanting to do genetic testing is that I want to give the family recurrence risk information for future children or reproductive information, that won't get paid for. And so we have a disconnect between what we feel is right for our patients and what the insurance company is willing to pay for.
Right. Well, when you're dealing with insurance companies, you only deal with the chief medical officer, no one else, because they're not doctors. And so they're making a clinical judgment, because remember, the effect of that denial of payment is it's probably not going to be done for most people. Why do you want to get reproductive risk assessment? There are 2 very good reasons. One is reproduction is one of the most essential exercises of human autonomy that there is, and we want it to be responsible, not haphazard. Number 2 is most of the time, if there's a risk of a major illness in a future offspring, there are ways to prevent the birth of such offspring, not conceiving, right? Prenatal genetic diagnosis with IVF, termination of pregnancy, all of which are a whole lot less expensive than taking care of that sick kid and adult. So it should be cost saving. So you could make an ethical argument, and then you can make an economic argument to appeal to the economic rationality of their business plan. That's what I would suggest you try, but only on the medical officer. It's a waste of time, because remember, insurance companies, if they're crudely run, make money by collecting premiums and paying out less in claims. If they're well run, they're doing that for the long run, not the short run. Now, this is going to get more complicated because the insurance business is now consolidating, and it's going to be 3 or 4 companies that are going to have an oligopoly. They will control most of the market. If the new Aetna-Cigna, is that the new merger, goes through, they'll have 50 million, I think, covered lives. United already has 75 million. So these companies are consolidating. It's giving them tremendous oligopolic power, which, of course, Americans don't like. So there's going to have to be policy fixes probably for this as well. Okay, thank you all very much. I'm going to get home before my travel papers expire.